Josh has informed me that everyone can't answer, so sorry about that.
Are you okay? You can't tell us.
We'll go ahead and get started. Welcome, everyone. We're going to do a quick update today on our 2018-2019 performance. Anita and Sarah are with us today. Sarah's on the line, but Anita's going to go ahead and walk us through the presentation. I'm going to hand it over, Anita, and let you take off.
Okay, thanks. So if you'll advance 2 slides, I believe.
No.
Oh, it's not. Okay, I'm not looking at the wrong thing then. Okay. Okay. So what I wanted to do today is to go over the 2 different programs that we as an ACO participate in. They are 2 pretty significant CMS programs. First is MIPS, which is the Merit-Based Incentive Payment System, and MSSP, the Medicare Shared Savings Program, which is the ACO that we participate in. So over the next few minutes, I want to share some details about both of those programs, and hopefully when I'm finished, you'll have a better understanding of how each one of those work. The 2 programs are completely different, but so often I hear people speak of them as one and the same. So I wanted to make sure that you understood the difference in the 2. Okay, if you'll advance. So I want to start talking just a little bit about MIPS. MIPS is a requirement for any clinician or clinician group that bills Medicare Part B and meets the eligibility requirements. And so to be eligible to participate in MIPS, a clinician or a clinician group must have more than 200 Medicare patients, must have more than $90,000 of allowed charges, and more than 200 covered services. So prior to forming our ACO, we each participated individually in MIPS, either at the individual clinician level or at the group level. So now that we're part of an ACO, we participate at the ACO level. And this means that we earn 1 score, and that that score covers each clinician or clinician group that is in the ACO. And so we have what MIPS calls the performance year. So we finished up our performance year. Let's talk about 2018. So 2018 was a performance year, and then the adjustment year is 2020. So what that means is how we performed in MIPS determines how we get reimbursed in 2020. And so the same thing for 2019. 2019 was a performance year, and how we perform in 19 will determine how we get reimbursed in 2021. So the Medicare Shared Savings Program, or MSSP, is not a required program. It's something that groups can join together and be a part of that group, and then they form the ACO. But once we're approved and we're in the ACO, then we have some requirements that we have to fulfill for quality and for cost. So if you'll advance the slide.
Can you advance it, Jennifer?
Okay, so for a Medicare Shared Savings Program, Track 1, there's 2 categories. There's the cost and quality. So for the cost category, CMS sets a benchmark that they expect that they want us to achieve. And if our expenditures for the year are less than the benchmark, we achieve savings. If not, then we suffered a loss. And if we achieve savings, in order to share in the savings, our quality score determines how much of the savings we can earn. And for the quality category, there are 23 measures that fall into 4 domains. So 10 measures in patient and caregiver experience, 4 in care coordination and patient safety, 6 measures in preventive health, and 3 measures in at-risk populations. And I'm going to go over those in a later slide. And so for the financial impact of this program, it's that we either earn savings or we don't. And in a Medicare Shared Savings Program, Track 1, it's an upside risk only. So if we earn savings, then we can share in that. If we don't, then we just remain neutral. There's nothing for us to share. All right, if you'll advance the slide, please. So for MIPS, Since we are in an ACO, our MIPS scoring is just a little bit different than what I call traditional MIPS, or it's for clinicians or clinician groups that are not part of an ACO. So for the traditional MIPS, there are 4 categories. The 4th one would be cost, but because we participate in the Medicare Shared Savings Program, we are considered a MIPS APM, and we only have to worry about 3 categories, and those categories are quality measures, which are worth 50%, promoting interoperability, which is worth 30, and improvement activities, which is 20. So in the quality category for the MIPS program, there are 11 measures, 10 specific quality measures, and 1 patient experience composite measure, which I'll go over again in a little bit. The PI category is worth 30 points, and we'll talk about that a little bit later. And the improvement activities category is worth 20 points, but CMS automatically gives that to us because we are part of an ACO. The reasoning behind that is it takes a lot of quality improvement work to bring large groups together like this, and they just give us that money because or those points because they know that we're doing that. And then we also have an opportunity to earn bonus points, which gets added to our final score. And that's the complex patient bonus, and it's worth up to 5 points. And we get those points based on the number of patients that we have that are considered dually eligible, and also by the number of patients in which we have done the HCCs, the HCC coding. And so the financial impact for this program is a positive or negative payment adjustment in the adjustment year. So, so again, in 2019, how we perform for MIPS, in 2021, our Medicare Part B reimbursement will either go up or down. And that score is credited to all the clinicians within the ACO. Okay, I feel advanced. So even though they're completely different, they do have one thing that connects them, and that's the CMS web interface quality measures. So we have to report our MIPS quality measures via the CMS web interface, and then the Medicare Shared Savings Program will use those quality measures. Okay. So a couple things I wanted to share about the quality scores for each one of the separate programs. For Medicare Shared Savings, each of the domains will count for 25% of the overall quality score. In performance year 1, which was 2018, all of the measures were pay for reporting. And in performance year 2 and 3 for us will be 19 and 20. Most of those measures will convert over to pay for performance. And then for MIPS, for the MIPS overall quality, overall score for MIPS, we have to earn at least 30 points to be considered successful. So if we earn less than 30 points, then we'll get a negative payment adjustment. If we earn 30 or more, then we will get a positive. If we can get up to 75 points, then we qualify for what they call the exceptional performance bonus, and that is if there's $500 million set aside for all entities that reach that 75 points, and then that has to be shared among all of them. And then there's also it's called an end-to-end bonus for each of the individual quality measures. We can get that end-to-end bonus if I submit the measures electronically. So I will be doing that. We did that in 2018, and we'll be doing that again this year, and that just means that I collect all of the data on an Excel spreadsheet and upload it. And what they're looking for there is that we can download clinical data out of our EHR and then upload it to them, and we are in the process of that. All right, so here's our timeline for how all of this works. So the first thing that happens is the beneficiary rank file is received. So I think right after Christmas, they released the patient rank list, and I was able to get that in a very simple Excel spreadsheet form. where it lists just the patients, their identifying information, what tax ID within the ACO they are attributed to, and very simply what measures they're ranked in. And then on Thursday of last week, they released the same information, but it's released in the actual tool that I have to use to collect the data and upload everything. And it's a pretty sophisticated Excel spreadsheet with lots of bells and whistles. So I've got that downloaded on Thursday, and we got that over to Cerner, and Cerner got that uploaded into our Healthy Intent platform. And this morning I was able to download that file with all of the clinical data. So now what's going to happen is I'm going to be validating all of that data. So ideally, what we would do is just look for patients who have gaps, or a patient that is not met in the spreadsheet, but I still like to go back through everything. I look at all of the yeses too. We do have the garbage in, garbage out that happens all of the time, and I try to prepare for a future audit. We've never been audited before, so I want to make sure that I'm confident that the data that they expect to be in the EHR is there before I say yes that it's there. So we may change some yeses to nos, but we'll change a lot of no's to yeses too, I'm sure. So that's the validation and pretty much the gaps manually abstracted. And then I will be working with each one of our regional and affiliate partners to collect the data for the patients that were attributed to them. So in that very simple spreadsheet that I got right after Christmas, I've already looked at that, and I know what patients are attributed to each one of those tax ID numbers or each one of those partners, and I've already started reaching out to them to make a plan for me to meet up with them and collect their data.
Anita, can I ask a question? Yeah. Last year, I believe 96% of the patients on the beneficiary rank file were Atrium Health primary tax ID patients. They were patients that were within the scope of the tax IDs that are tied to Atrium Health proper. Was it similar this year, or are there?
Okay, so it was 92% last year, close.
Oh,
Yeah, that's sorry. Okay. And so this year is 88%.
Okay.
And the way I determined that is 88% of the patients on the list belong to a tax ID number that I know is active on Cerner.
Okay.
So, but also I'm just going to use Ortho Carolina as an example, as well as Sienta. Both of those are local specialists, and I have been able to find most all of their patients are receiving primary care here. So I'm going to be able to get most of that information out of Cerner.
I was just wondering how much manual abstraction you have. It's still relatively small.
Mm-hmm.
Okay, good.
Yeah. Okay, next slide. So it takes teamwork to make this happen. And thanks to each of our regional and affiliate partners last year, we earned a perfect score for our MIPS program. So we were able to get 50 points for quality, 30 for PI, 20 for improvement activities. We earned 3 points out of 5 for the complex patient bonus, but there was no need to use it because we already had the perfect score, and you can't get more than 100 points. So go back just for a second. So for 2018, the financial impact was a positive 1.68% upward adjustment. So on our Medicare Part B charges for this year. All right, next slide. So how do we look in 2019? Well, it's really difficult to know for sure how we're doing because we have measures that we can monitor throughout the year. But we don't know what patients are going to be sent to us. So in our Healthy Intent platform, we have we have all of the Atrium all the atrium data, or the canopy data, the Cerner data, and then we have some claims coming in from some of our regionals and affiliates, but that looks at the whole population. So when we do this, CMS gives us that rank file, and it's just, I only have 2,600 patients on there this year. So we don't really know exactly how it's going to look, but directionally, it should, we're expecting to look about like we did last year.
The promoting interoperability should be 100%, right? We should get all 30% of those points.
Well, we did last year.
Okay.
We're not really sure where we are with that this year. The scoring changed a little bit. The measures got a little bit harder, and it is a little bit more difficult to meet all of those measures. Plus, we don't know how all of our regional and affiliates did, but if it's not 30, we're expecting it to be pretty close.
Okay.
So. One thing that I want to share for 2019 is that we do expect that positive or that maximum benefit, that maximum financial impact to go down. In 2017, for folks that earned a perfect score, they were able to get a 1.88% upward adjustment. For 2000, that was 17 performance. In 18 performance, it dropped to 1.68. And I just saw something last night. I didn't really have time to study it really good before our meeting this morning, but it was a document from CMS that told how many clinicians across the country met were successful performers, and it went up considerably from 2017 to 2018. So we expect it to continue to rise, and because there's a share in that money, the more people or more entities that are successful, the less of the financial impact will be for each. So we do expect that to go down. Next slide. So really quickly, Medicare Shared Savings Program, if you'll remember, has 23 measures. 10 of those are the web interface, 10 patient experience measures, and 3 administrative claims. And for MIPS, there's 11. So they look at the 10 web interface measures and 1 patient experience measure, which is a composite of all 10. All right, next slide. So these are the 10 web interface measures, and I tried to show you how they impact each one of the programs. So the first 2 columns there for MIPS, if there's an X in that first column, it's pay for performance. So our score actually matters. And then the second column identifies the measures that are still pay for reporting. The next MIPS column just says whether it's included in MIPS. And then that very last column, I just wanted to share what our performance would need to be in each one of those measures for us to reach the 90th percentile. And so for MIPS, it's scored, we earn points based on what decile we fall in, what decile our performance falls in. Okay, the next slide. Same thing, same format, but this is the CAP survey measures. So out of the 10, 7 of them are pay for performance, 3 of them are pay for reporting. Next slide. These are the 3 administrative claims measures that only apply to MIPS. They are not MSSP, not included in MIPS. Only 1 of them is pay for performance, and the other 2 are pay for reporting. Next slide. This is just a list for your reference. If you have a copy of the slides, all of those measures are on one slide for you. All right, so some changes. Not a lot of changes in our measures for this year. The only thing that changed for 2019 from 18 is the tobacco measure. Last year we performed pretty poorly on our tobacco measure because of the way the specifications were written. It was pretty difficult for us to meet that, and apparently CMS heard that. A lot of folks across the country had the same concern. So they changed the numerator definition just a little bit, which will allow us to do much better on our performance for that measure. And they're going to retro that back to 2019 and going forward. And for 2020, there's no other changes in our measures. So it'll be the same the same 10 exact measures and that composite for for patient experience. Okay, so we'll talk a little bit now about promoting interoperability. Sarah Reed is on the line. She wasn't able to be here today, so I told her I would go over her slides for her, but she's on the line if we have any questions. So again, the way we earn our 30 points for the PI category is that each individual tax ID number will continue to report their own performance in promoting interoperability. They will upload their information to the QPP site. And once all of that is done, then CMS will calculate a weighted average of all of the 10s, and then that will be the one score that will be applied to our ACO. And again, that category is worth 30 points. All right. So Atrium Health has, I'm going to have to read some of these because I'm not as familiar with this content as Sarah is. So Atrium has 31 of the 10s. That accounts for about 2/3 of our total ACO. In 2018, all the 10s maxed out our possible points. And again, what she's saying here is the same thing that I said on the last slide about the scores are aggregated for a one score that will apply to the whole ACO. Some of our 10s are considered excluded because of the type of work that they do. They might be excluded because they're not patient facing, or they're considered a rural health center. Those that are excluded, that doesn't mean that their scores are reweighted to other categories. And then we receive the one score. Okay, next slide. I didn't have that one in here. I think we have, she took a lot of these slides out, so let's just keep going really quick. Just go through some of these. Sarah, you want to jump on? Can you see the slides? Can you unmute? You can't. There's no way. Okay.
She's gonna call in to my line. Okay.
So this was the original slides, and we did an update taking some of these slides out. So let me just read what I have here. She is currently assessing our performance for 2019. I believe it's going to be about a week or two before she has all of that information together. We have opted to, within Atrium Health, we've opted to reweight one of the categories, the support electronic referral loops by receiving and incorporating health information was.
Hey Sarah, hold on one second, okay? Sarah, you're on. Sarah, you're gonna have to mute your computer, please. Are you all set?
Can you just keep clicking through some of those slides?
Sure.
I think the very last one is the one that we need. Okay, we can stop here. This is good. So,
Sarah. That's Sarah.
I'm here. The slides are just not the slides from the same link. These aren't the ones that we had updated. Right, so right. These are all things that were accurate as of last year.
Can you see the slide that's up now?
I can.
You want to go ahead and talk about it then?
Yeah, so in 2020, there were very minimal changes to the PI program. For those of you familiar with the PDMP piece, they did make this optional. So it will require a yes or no instead of a numerator denominator, which is good in the sense of it doesn't necessarily have to be a certified report. You can do screenshots if it's something that your EMR is capable of, but you can't necessarily capture in a report form. The Verified Opioid Treatment Agreement was removed for 2020. I think there was just too much difficulty in capturing that whole cumulative 30-day window, so they decided to remove that. The health information exchange measures, they have a way to do an exclusion if there's less than 100 in the denominator, and you can also reweight to respective measures, some for patient access. So if your group doesn't have, like some of the specialties, you may not have a lot of TOCs going out or ClinRec stuff coming in, then you could potentially take an exclusion and reweight to the patient access measure. And then the ClinRec measure will again go ahead and be an exclusion if you have less than 100, but even still you would have to report a 1 in the numerator in order to attest at all. So they are kind of doing that so that they know that you at least have the functionality. One thing that I found as we've gone through this both in 2018 and 2019, I get a lot of questions at the end of the year on whether or not groups have to participate at all. A lot of this stuff is posted earlier in the year, so I would suggest if your group is unsure of whether or not you're going to have to do PI, to go ahead and check your participation status. That way you can see if there's any possibilities for hardships or things like organizational changes where you changed EMR and you may need to go ahead and take that hardship. So next slide. Did it go to the next slide and I just can't see it?
Yeah, it's the PI scoring methodology. It's the last slide.
Okay, well then there isn't much that changed there. The only thing is the e-prescribing did change a little bit in that it will still be worth 10 points, but you are losing that 5-point bonus for the Verify Opioid Treatment Agreement. Again, there's some potential to reweight categories. This year you were allowed to reweight your clinical reconciliation or that support electronic referral loop by receiving and incorporating health information if for some reason you couldn't implement it in time. They did remove that as a possibility next year. So everyone will need to at least have that 1 in the numerator to show that they have the functionality. If you guys remember from years past, they are slowly dwindling down the number of points you can get for PI, and they're making the measures extremely difficult. We have found that we talked to groups all across North Carolina, especially those on Epic and some on Cerner and some on Allscripts. And everyone struggles with those health information exchange measures. And since those are going to be a good bulk of the points, and there's not a lot of bonus points like there have been in the past, I think scores across the nation are probably going to drop in these categories. If you know from the TOC piece, it really is dependent on who else is participating. If you have a lot of groups in your area, or if you're out in a rural area with groups who don't participate in meaningful use or PI, then you're kind of at a loss because if you're sending them to places where they don't have this access, you're going to get basically penalized to some degree because you're going to have to still count that in your denominator, but not in your numerator. So I think across the board, we're probably going to see some drops. And I think that was my last slide.
Yeah. Okay, we can.
Are there any questions or?
We're not going to go over those slides. She had revised them. So is that the very last slide?
I believe so.
Presentation? Okay. And I think the only thing that I had left on the agenda to talk about, I've already talked about, and that was the patients on the patient rank file that are attributed to our affiliate and regional partners. And
that slide is not accurate. That needs to be deleted.
We turned it off.
Okay.
So that's all I had to talk about today. Does anybody have any questions for me or Sarah?
I mean, what do you think our biggest risks are, both in the interoperability and then the overall? And are there things that we can do to, we can't do anything for 2019 because the year's over, I understand, but with no changes in 2020, are there things that we could start to work on early this year in order to address areas where you think that there's either a risk or an opportunity for improvement?
So I'll know a little bit better once I start collecting the data.
Okay.
I do think that we're performing better than we did last year.
Okay.
I'm very encouraged with the change in the tobacco screening measure. We didn't earn enough to even make the 30th percentile last year. So luckily for the MSSP, everything was paid for reporting.
Right.
And we had enough bonus points in MIPS to cover us from that. So I've already looked preliminarily before I go through everything. We're already at 50. No, I think we're at 85% for tobacco electronically. Now I have to go back through it manually. but we were only 43% last year what I submitted. So just at a very quick glance at our performance electronically, I just downloaded it just really quickly before I came here.
Sure.
The scores look somewhat better than they did last year. So I'm really encouraged by that in the quality category. So I'm hoping to have everything finished by the end of February. That's my goal. We have until the end of March to finish it and submit it. We have less measures this year than we did last year, and we've got 2 extra weeks.
Yeah.
Plus we've got a year of experience behind our back.
Yeah.
So I feel a lot more confident about it this year. So I think we can finish pretty quickly. So I should know something by at least an idea from the quality side of how we look about mid-February, or at least by the end of February.
And then Sarah, can you still hear us and speak?
Yeah, I'm still here. I just muted my phone.
Okay, on the interoperability side, you said that you expected everyone to go down this year. Can you talk about those areas where you expect everyone to drop in? And are there things that we can do in order to not drop as much as others?
Yeah, so really it's the both the clinical reconciliation, so that receiving and incorporating health information, and then the transition to care measure, or the support electronic referral loops by sending health information. What we found just across the board is there are many groups who don't participate, which there are things that can be done around that, but you also have to understand that you're asking groups who may not participate in PI to do work outside of what their scope is, or outside of what they feel is necessary. So it's difficult to rope others into something that doesn't impact them.
It does impact them because it impacts the rest of us, right? And so, I mean, if there are things that we could help support in some of those practices where it's not going on in a meaningful way, where we take the burden off some of them, but then improve the score overall, that might be the 1.68% represented somewhere between $2.5 and $4 million in additional payment to our clinicians who are part of the ACO. So it's a material number.
I'm speaking to those who are outside of the ACO. Yes, for those who are part of the ACO, sure, we can leverage that. But for groups who are out in, say, Anson County or some of those smaller groups, those rural clinics may not be impacted.
Well, but
They're
still part of the ACO. I guess.
Right, not necessarily everyone we're referring to.
Oh, I
think
see what you're saying.
What she's saying is for that referral, closing that referral loop, that transition of care document, submitting it and receiving it for some of our ACO participants that are in rural areas, if they are trying to send a transition of care document to a facility that's not part of our ACO, they may not have the ability to accept it.
And John, and I did give John an idea of how we might at least try to solve for that without making it a heavy burden for some of the non-ACO referral participants this morning. So we're going to look and see if we can maybe come up with a way to at least ensure that there's a capacity to send and for them to look up, which might count as receiving. Where it won't cost them anything and it won't add a burden to the work that they're doing.
Okay.
Yeah, we're certainly open to suggestion. We've had this in the past where we had spoke about Cerner had a way to develop like an inbox where we would pay for their inbox. Yeah. But in some of those conversations we had, the way it works is they'd have to at least have some sort of agreement in that they're going to check the box, because it's supposed to be about receipt of that and actually doing some sort of work with it. So again, it would probably be forming some relationships with some of those groups who might be willing to do that.
Yeah.
And we haven't had the resource to do it, and there hasn't been anybody doing that work. But certainly, if there are ways to work around it, we're open to it. From an IT perspective, we've done about all we can do, and I've scheduled some time with some of the groups, some of the quality folks who may be able to help support some of the operations piece of this. And I met with Marquis as well, because again, some of the feedback we've received is that the transition to care process we use today doesn't really support the intent of the measure. A lot of your practices are getting TOCs after the fact, after the patient's already seen them, because that's how we close the loop.
Yeah.
So there definitely needs to be some work around that as well. For clinical reconciliation, that's the other area where we're going to have some work to do. We've yet to roll that out, mainly because the tool that Cerner's developed is very burdensome. And so we reweighted this year to TOC, but we have to do it next year. And so we plan to go live with that in Q2. So we will definitely need support from an operations perspective in getting providers and nursing staff to do some of this work. Again, the Cerner tool is a bit laborious, and they don't plan to have any sort of advanced interop work done until at least Q1 of 2021 for us. So we'll really need some support on that once the tool is available for providers.
We should add that to our IS work group so that I can understand what that means. Yeah, because I haven't even heard about any of this until this morning, so.
Hey, this is Erica from Ortho Carolina. We're running into the same issue. We are not going to be doing that and bringing that into our system because with all scripts, it too is extremely burdensome. So we are not going to be doing that for 2020.
But we may want to get with the Premier folks and put this on the list of issues to bring forward to CMS, because if we're having the issue and you're having the issue and we're the largest providers in this region and we're having a hard time doing this, don't know how other people are going to do it, right? Like,
well, and all the groups across North Carolina have voiced the same opinion. And when the final rule came out or the proposed rule came out, I wrote like a dissertation about it. They obviously didn't read. But yeah, it's very difficult for everyone, especially if your EMR allows for SureScripts data to pull in. When we first trialed this, for one patient, almost 90 different medications pulled in to reconcile. And it's just, there's no way that staff will have time to do that work.
Yeah, SureScripts will not install the scrubber to see that information, and that's where we're running into the problem.
yeah. Again, I
we
think it's
actually
like
were able
but
to
it's like
remove
the-
SureScripts,
I get it, but
which
it's
has
like
helped a little bit.
it's like the tobacco cessation issue, right? They proposed the rule, they made the change, they put it in place, and then they went, look, so then they went backwards and said, we're gonna rescore this for 2019. I don't think we should give up just because a dissertation was written and wasn't reviewed or looked at or considered. I think we need to continue to raise the issue, and maybe we can reach out to our Premier friends and Richard and those guys, because they have a closer relationship with CMS in this space and they can bring it forward.
And then I would like to just kind of piggyback on that. I don't know what we are supposed to do. Ours isn't necessarily rural areas, but for the direct messaging IDs, when we have those smaller groups, I mean, we refer to a pediatric surgical group here at Stolen Paper.
Yeah.
And that's a very large group that we would send to, and they continue. I mean, that is something that will never, it's in our denominator, but never going to be in our numerator. So I'm not sure what we are to do with those groups that don't have that direct messaging ID where we're trying to complete and close the loop.
Right, I think we might have an idea, we're gonna work on it, but I don't want to tell you about it until I know if it's even a possibility.
Like, I want to make sure I know I can do it.
Well, I mean,
Okay.
or at least do it for not everybody, but if we say, here's the 20% of the groups that represent 80% of the volume, could we do it for them? We'll still
Right.
score high enough
Yeah.
to get the points without, making sure that for patient care, we should be able to do it in general.
Mhm.
The fact that we can't is because of how complicated the interoperability standards are across, and eventually the government's gonna they're gonna force it. In the interim, if there's 20% of the practices that we refer to, even those that are out of network, if we can solve for that 20% that
That'd be great.
represent 80%, John and I are gonna,
Wonderful.
we're gonna chase that rabbit down a hole and see if we can, or catch a fish or something, I don't know.
And just also, from an internal standpoint for that tobacco measure specifically, we did have a conversation. I spoke with our IAS team, Jonna and those folks, because they're making some HCC changes and how things appear for the physicians. And so I asked her to make sure that the measure that because they're moving things around to make more sense. I said, can you please double check the measure? Because I know it's very specific to make sure it's going to meet the requirements. And so she was going to look into that. So I'm guessing Sarah, she'll probably get in touch with you around that, or potentially with Nita or somebody. But I wanted to make sure that as we make those changes, if we're looking at things to improve HCC capabilities for our physicians, I want to align that with things to make sure it's meeting the measures that we need, so that we're not picking something that is not going to meet the measure. And so our physicians are documenting it, And then they get frustrated because why didn't we meet the measure? I documented it. And then it's because we missed on a measure that there are 47 codes and we picked, the 33 that don't work.
So for that tobacco measure, for those of us who are not in Atrium, what are you wanting us to make sure that we document through our EMR system?
So it's going to be a whole lot easier for 2019 and going forward. In 2018, let me back up and give you just a piece of history. There are several different ways that you can submit your quality data to CMS for the MIPS program. There's the claims-based and registry and EHR, CMS web interface, and there's some QCDR stuff. So there's lots of different ways that you can submit. And each one of those different submission methods, there's a specification written for each one of those methods. So we can take the tobacco screening measure, and there's the claims-based specification and the registry-based, and then the CMS web interface. So what they found was that the CMS web interface specification was written essentially incorrectly, which made it very, very difficult for us to meet the measure. So the way it was written for 2018, a patient needed to be assessed for tobacco use within a 24-month period. So it would have been the reporting year or the year before. So for 2018, if a patient was assessed for tobacco use at any time in 2017 or 18, that would count for the tobacco assessment. And then the next step is, was the patient identified as a tobacco user? If the patient was identified as a tobacco user, we had to look at the most recent time they were assessed. And a tobacco cessation intervention would have had to have been done at that encounter or after. So my one example was that just hurt my feelings so bad is that I didn't find a whole lot of tobacco users, honestly, only about 10%. And it was really difficult to find a cessation intervention. So one particular patient had been most recently assessed in December and had a really good note in the physician's office visit note where they'd had a really good conversation about stopping smoking. They couldn't use it because that happened in September and the patient was most recently assessed again in December. So because of that, our scores, if I remember correctly, out of the 248 patients that I had to report on for that measure, only 23 were identified as tobacco users, and I only found 10.
How can that be?
I know.
People lie.
Yeah, well, they probably do.
I'm just saying, people lie.
Okay, so that's what was so difficult, is that cessation intervention had to be done at the most recent time that they were identified or later. The change now is they have to have been assessed for tobacco use in that 24-month time period, and any cessation intervention done in that 24-month time period will count. So
Do we have to also say if they're a tobacco user?
So that was another thing. That was another thing. CMS offers a weekly call. So if you, once we get started, I think it may start tomorrow. I think that it does.
We're signed up, yeah.
Every Wednesday afternoon, there's a web interface support call with CMS that you can log into, and folks from all over the country that are submitting data via the CMS web interface can participate. And they usually have a few PowerPoint slides, and they go over some hot topics in about the first 15 minutes, and then the rest of the hour is patients writing in questions or calling in and asking questions, and it can get pretty intense because people don't agree with the interpretation of the specifications. So last year for 2018, they said that we had to assess both smoking and smokeless tobacco.
Mm-hmm.
Well, a few years before, when the meaningful use requirements came out, they gave us this list of things
8 different ones, right?
that we
Yeah,
have to
buckets.
have, 8 different buckets that we have to have in the EHR, and every one of them is references smoking.
Right.
None of them referenced
Tobacco
to
use.
smokeless tobacco or oral tobacco. So now for 2018, they're like, if it just says smoker, then you can't count it because you didn't assess for
Right.
the oral tobacco. So lots of people fixed that in their EHR systems, and now they're saying if it says former smoker or never smoker, you can count that as an assessment. You don't have to assess both. So they've made it a whole lot easier for 2019 and going forward.
So we can just assess a tobacco product, if you will, and we don't have to also say if I'm a smoker, then tobacco user. Okay, that's what I
So
thought.
we did go through an exercise starting around March or April of last year where we tried to, we brought some folks together and we talked about how we documented our tobacco, and I tried to help guide based on the ACO specification, and so we now have a separate section for smoked tobacco and for smokeless or oral tobacco. And now we don't need it.
Yes.
But that's okay.
But
It's-
it may come
it's-
back and you never know.
I never know. So it's,
I feel like it just depends on who's answering the question on the call.
yeah, it is. I mean, I think for better patient care, I mean, we've got that, and you know, and my example for that is if you ask my dad if he smokes, he's gonna tell you no, because he doesn't. But if you don't ask him if he's using oral tobacco, he won't tell you that he's chewed tobacco for the last 45 years. So, yeah, he's not gonna tell you that. So I think for good patient care, I like that we have it that way. And vaping.
Yeah, that adds a whole nother thing.
Yeah,
right? People
so-
will say they don't smoke if they vape.
Yeah.
Right, well, so the way CMS defined that particular measure was that it had to be a substance from the tobacco leaf. So the cigarette has the tobacco leaf, or the chewed tobacco has the tobacco leaf, whereas the vaping isn't
Extra.
it isn't a tobacco leaf, so it does not count
Yeah, we just
as
put that in
tobacco.
as a separate question.
So we have two. We've created 3 different buckets now. We've got our smoked, our oral, and our vapes.
Same.
So
Okay.
That's how you only get 10 smokers though. Like, do you smoke? No.
Yeah, only-
100% no.
yeah.
I'm walking around North Carolina. I know there's more than 10%.
Well, it's 10% of our sample. So
Okay.
yeah. Anyway,
Pretty sure that that's not accurate.
yeah, probably not. But in the case of an audit, we can prove it. So that's all I care about. Any other questions for me on the quality
Thank you.
piece, or for Sarah on promoting interoperability?
Thank you, Sarah.
You guys both rock. I talked to Anita
Thank
a
you.
couple days ago and you guys are doing rock star work. So you guys are killing it. Love it.
That's a great job. Thank you.
We appreciate it.
Right, everyone, thank you. We will send out a version of this recorded call. There will be a chance for you to submit questions if you had any. We'll direct those to the right individuals. We'll also attach the right PowerPoint slides. Please feel free to reach out via email if you need anything. Thanks so much. Have a great day.
Thank you.
Thanks, Sarah.